بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا يا كريم. Dear colleagues, I will present now inshallah this lecture about imaging of the elbow joint, and this will complete the series of imaging of the major joints I have discussed before: imaging of the knee, imaging of the shoulder, imaging of the hip, imaging of the wrist, and the ankle joint. Then the remaining one of the big joints is the elbow, and now we are going to discuss this joint. You know that we have the MRI machines of different types: the closed machine, the open MRI, as well as the extremity magnet, which is one of the good tools for examination of our joint, which is the elbow. Then we usually examine the joint for local joint complaints like the presence of pain, trauma, or swelling, or searching for inflammatory or neoplastic lesions. We use usually the surface coil, and we examine a single joint at a time. The patient position may be in the supine position with the arm beside the patient, as you can see here, or the patient may be put into the prone position, and this position is known as the swimmer's position or the Superman position. Then a third position, which is sometimes used for evaluation of particular tendons in the elbow, around the elbow, with commonly the biceps. This is known as the flexed abducted supinated view, and in this position you can have this very good image for the region of the proximal part of the radius and the ulna, where you can see the biceps tendon going to the radius and the brachialis tendon going to the ulna. And one of the simple ways to discriminate between the radius and the ulna is looking for this muscle, which is circumferentially surrounding the proximal part of the radial head or the radial shaft, and this is the supinator muscle. Then if you see this muscle, and this will be the radius, and this will be the biceps tendon. Then the protocol will include the axial, the sagittal, and the coronal images. We usually use the axial image as a reference to design the coronal and sagittal images. The coronal images are obtained parallel to the axis of the distal part of the humerus, as you can see in this axial image, while the sagittal images are aligned perpendicular to the long axis of the distal part of the humerus. And as a simple way to remember the protocol, which is easy, is that you may have the T1 and T2 weighted images either with or without fat suppression in all the three imaging planes, which are the axial, the sagittal, and the coronal. The field of view should be small, in the range of 12 to 16 centimeter, so that you can better identify the anatomy and the pathology. The slice thickness is in the range of 3 millimeter slice thickness, and we may leave 1 millimeter inter-slice gap. Then the structures that will appear of low signal in the T1 and T2 weighted images are, as you remember, those which do not contain mobile protons, such as the cortex of the bone, the ligaments and tendons, and the calcifications, of course. And in this particular joint, we do not have a specific other items to appear of low signal in the T1 and T2 weighted images. Then fat will appear of high signal in the T1 and low signal in the T2, while fluid will appear of low signal in the T1 and high signal in the T2 weighted images. MR arthrography is one of the good diagnostic tools, particularly in this elbow joint, and we usually inject a minimal amount of gadolinium in the range of half a millimeter, diluted with about 10 millimeters saline, and this amount of fluid is injected through this particular anatomic triangle, which is a good approach for the elbow joint space. This triangle is made of the lateral epicondyle, the radial head, and the olecranian process. Between these three structures, you can introduce your needle after, of course, sterilization and making some local anesthesia. Then you inject the contrast under screen to be sure that you are inside the elbow joint. We use frequently the MR arthrography looking for loose bodies or osteochondral lesions, and in particular in some cases of ulnar collateral ligament injury. Then the bones in the elbow include the distal part of the humerus with the complex anatomy, the proximal part of the ulna, and the radius as well. Then this is the radial fossa, and this is the lateral epicondyle, and this is of course the medial epicondyle, which is more prominent than the lateral epicondyle. And this is the olecranian fossa. We are looking posterior to the humerus, and this is the coronoid fossa if you are looking from the anterior aspect of the humerus. This is the capitulum, this is the capitulum, and this is the trochlea. The trochlea is articulating with the ulna, and the capitulum will articulate with the radial head. Then this is a view for the proximal part of the ulna, and you can see the trochlear notch, and you can see the coronoid tip, and you can see the radial fossa for the radial head to articulate here, and this is the sublime tubercle for attachment of the medial collateral ligament, and the base of the coronoid process is here, the ulnar tuberosity is here, and of course this is the olecranian process. Then the olecranian fossa has two articular surfaces which are covered by articular cartilage except for a small area in between, and this area may appear like this in MR images, so that be careful not to mistake this as a loose body, because this is the bare area, let us call it the bare area, which is not covered by articular cartilage between the two cavities of the olecranian fossa. Then this is just a drawing showing the attachment of the different ligaments around the elbow, but don't bother yourself by this drawing. Now I will explain in details how these tendons and ligaments can be identified. You know that we may have a policy or an approach for evaluation of each joint in the human body, and I thought very long time, how can we approach simply the anatomy and the pathology of the elbow joint. Finally, I came to a suggestion that if I use the protocol that I have used in the ankle joint, it would be more simple than other ways in handling evaluation of the elbow joint. Then in this domain we will handle the elbow joint from the four main directions, from the anterior and the posterior, from the lateral and medial, looking for these important structures which are the tendons and ligaments. Then finally we may look for the nerves and osteochondral lesions, as I have proceeded with the ankle joint. Then starting by the posterior compartment, we have three main issues. The first one is the evaluation of the triceps tendon, the anconeus muscle, and the olecranian bursa. And then you know that the triceps tendon has three sides of, or three heads to be inserted into the olecranial process. And for simplicity, you should know that the superficial part of the tendon is made of the lateral and the long head of the triceps muscle, while the deep part of the tendon is made of the medial head of the triceps muscle. Then they all insert into the olecranian process, and frequently there is usually rupture of the long head and the lateral head, which are commonly inserted by a common tendon. But sometimes you can see complete rupture of the triceps tendon involving as well the medial head. Then this is the triceps tendon, which is made of three heads: the lateral, the long, and the medial one. The lateral and the long heads both starts by the letter L. Then they are combined into a common, strong tendon, which inserts into the olecranian process. And the medial head is relatively small. It inserts also into the olecranian process, but you cannot see actually a tendon which is similar to the superficial part of the muscle. Then here you can easily appreciate the triceps tendon. This is the triceps tendon, the long and the lateral heads, and this is the medial head inserting into the superior surface of the olecranian process. An injury of the triceps tendon is an uncommon injury, and is considered the least common injury around the elbow. This injury can be diagnosed easily clinically and also from the plain X-ray, where you can see that many times you see an avulsed bony fragment from the olecranian process together with the soft tissue swelling around the posterior aspect of the lower part of the arm. And then you may suspect in good history that the tendon is ruptured. Then this tendon usually requires surgical repair, so you will need the help of MRI to confirm the diagnosis and to look for what part of the tendon that has been ruptured. Actually, the lateral view of the elbow is one of the helpful radiologic techniques if it showed the presence of an avulsed bony fragment, as well as the soft tissue swelling due to hemorrhage and edema around the avulsed fragment. And this is X-ray and the MRI showing rupture of the superficial part of the tendon, which encompasses the lateral and the long heads of the biceps. This is the medial head of the biceps, which is intact, and this arrow points to the combined tendon of the lateral and the long head, which is avulsed. And in the plain X-ray, you can see the avulsed bony fragment. And this is lateral X-ray of the elbow, and MRI T2 weighted image with fat suppression, and you can see the avulsion of the superficial part of the triceps tendon, and involving the long and the lateral heads, while the medial head looks to be intact. In the lateral view of the X-ray, you can see the avulsed bony fragment and the swelling related to the fragment. MRI is important to differentiate between complete and partial tendon ruptures. And in this particular example, you can see that about 3/4 of the tendon has been ruptured and are retracted for a distance of about 3 centimeters, together with an avulsed bony fragment from the olecranian process. And you can see that the deep part of the tendon is intact, and the ruptured tendon is surrounded by extensive soft tissue edema and contusion. And here, this is avulsion or rupture of the superficial part of the tendon in this sagittal T2 fat suppressed weighted images. This arrow points to the tip of the avulsed superficial part of the tendon, which includes the long and lateral heads. But this T, which is presented in green, refers to the deep part of the tendon, which is made by the medial head, which is intact. And this F points to the fat, which is present anterior to the tendon normally, but because this image is a fat suppressed image, you can see the dark signal of the fat. Then superficial to the ruptured site, you can see an area of high signal representing hemorrhage and edema. And this is a full thickness tear, let us say that, or complete avulsion of the triceps tendon involving all its three components, the superficial part and the deep part as well, together with extensive edema around. Then sometimes you can see that the tendon is intact, but it shows abnormal increased signal or in the form of intermediate signal, similar to many of the tendons that show these degenerative changes. Particularly, you may remember the supraspinatus tendon. If it showed intermediate signal in the T1 and T2 weighted image, you can say that this is related to tendinopathy. And here also the same rule applies for the triceps tendon, where you can see an intermediate signal in the tendon, and this is tendinopathy, but the tendon is not torn. Then the third issue here is the olecranial bursa, and this bursa will accumulate fluid if it is inflamed. And there are some of the risk factors, including alcohol, diabetes, hemodialysis, and the use of anticoagulants. And the bursa may be inflamed secondary to bacteria or other inflammatory conditions. And you may see swelling only of the bursa posterior to the olecranial process, but sometimes you can see pain and erythema, and at that time you should suspect that there may be septic infection of the bursa, or maybe due to the presence of gout. Then the causes of olecranial bursitis may include the excessive use, and this is known as the student's elbow, or repetitive trauma or infection by septic organisms, or inflammation, as in cases of rheumatoid, gout, and the pseudo-gout, as well as the pigmented vellonodular synovitis. In the X-ray, you will see just a swelling, soft tissue swelling, which is related to the posterior aspect of the olecranial and distal part of the humerus. If there is a case of trauma, then you may see some fractures, and in cases of gout and pseudo-gout, you may see some calcific foci here, which are known as tophi. Then the CT findings will show that the bursa is distended by fluid, and we see calcium or loose bodies in cases of gout or the pseudo-gout, and elbow joint effusion may be sometimes detected as well. And this is MRI of olecranial bursitis. This is sagittal T1 and sagittal T2. You can see that the bursa is distended by fluid of low signal in the T1 and high signal in the T2. Look how beautiful the appearance of the triceps tendon, which is of course of normal signal and intact, inserting into the olecranial process. This is the normal appearance of the lateral X-ray of the elbow, and this is an appearance of olecranial bursitis secondary to the presence of gout. And as I have said, in gout you may see just distension of the bursa by fluid, or you may also see some calcific tophi related to the olecranial. Then we have finished the one of the compartments of the elbow, which is the posterior compartment. Then we came to the anterior compartment, and where we would like to discuss the biceps tendon and the brachialis tendon, what's known as the supinator syndrome, as well as the bicipitoradial bursitis. Then if you look to the anatomy of the anterior compartment, which is better appreciated in the axial images, and this is the distal part of the humerus, and here is the tip of the olecranium where the triceps tendon is inserting. Then on the medial aspect you'll see the pronator teres, and in the middle of the distal part of the forearm you see the bulky muscle, which is the brachialis. Then the brachioradialis is located laterally, and also the anconeus muscle is located laterally. And sometimes you may see what's known as anconeus epitrochlearis muscle, which is located medially here, overlying the site of the ulnar nerve, as I will discuss later on. Then this arrow points to the tendon of the biceps muscle going distally to reach its attachment in the radial tuberosity. Then if you look to the axial image, you should appreciate that the medial epicondyle is more prominent than the lateral epicondyle. The medial epicondyle gives attachment to the common flexor tendons, while the lateral epicondyle gives attachment to the common extensor tendon. And this is the brachialis, as I have mentioned. This is the pronator teres, the brachioradialis, and the extensor carpi radialis brevis. And here you can see the tendon of the long head of the biceps. Then lower down you can easily appreciate the head of the radius and the proximal radio-ulnar joint, and this is the ulna, of course. Here you see the extensor group of muscles, the flexor group of muscles, which are the pronator teres, the flexor carpi radialis, the part of the triceps muscle, and the flexor carpi ulnaris. Then here you see the brachioradialis, the extensor carpi radialis longus, the extensor carpi radialis brevis, and you remember the anconeus muscle, which is located laterally. And here you can identify the some of the cords of the ulnar nerve. I will discuss it in full details after that. Then this tendon is, as I have mentioned, the biceps tendon, and here you can see the brachialis tendon. Both tendons are going to insert into this one into the ulna and this one into the radius. Then this is the anatomy in order to follow the course of the biceps tendon, starting in the lower arm. Then you are going towards the elbow, and this here you can also proceed towards the region of the elbow, and finally you can easily appreciate the biceps and the brachialis tendon. The biceps will go to the radial tuberosity, and the brachialis tendon will go to the ulnar tuberosity. And this is the final destination, where you can see the biceps tendon going to the radius, and here is the famous muscle, which is the supinator muscle, as I have mentioned before. And this arrow points to the brachialis tendon going to the ulnar tuberosity. Then the biceps tendon is considered the engine for rotating the forearm. Then it inserts into the radial tuberosity by two insertion sites, and this tendon can be easily appreciated for a long distance using this technique, which I have mentioned, the flexor abductor supinator position. And this is the radius identified by the supinator muscle, and this is the biceps tendon, and this is the brachialis tendon. Then the distal tendon of the biceps usually rupture if it is maximally contracted against load, and there may be the tendon is usually completely torn, but sometimes you can see partial tears of this tendon. Then the diagnosis is usually easy by clinical examination, but sometimes you need the help of MRI to identify the site of the tendon. Then this is the drawing showing the rupture of the biceps tendon, which is usually retracted above in the arm, and this is the an MRI showing the ruptured, retracted, tortuous tendon of the biceps muscle. Then as I have mentioned, MRI is occasionally used to confirm the diagnosis, but the diagnosis is easy on clinical examination. Then biceps tendon ruptured usually due to trauma from a forcible flexion of the elbow. And visualization of the tendon is crucial for preoperative planning. Then here you see that the tendon of the biceps has been avulsed and is retracted into the forearm. And this is an example of rupture of the distal part of the biceps tendon, which is wavy, surrounded by extensive soft tissue, high signal due to edema and hemorrhage. And this is also an example. In the see, this is the site of the this is the brachialis muscle, you remember, and this is the site of the biceps tendon, which is now torn and is surrounded by extensive soft tissue edema and hemorrhage. This is the flexed abducted supinated position, or FABS, and here you see this is the radius and this is the ulna. The radius is surrounded by the supinator muscle, and the distal part of the biceps tendon showed some increased signal, especially of this part, while the remaining part is intact, and this may diagnose the possibility of partial tear. Then you can see also some fluid surrounding the site of the injury. This is the normal appearance of the biceps tendon inserting into the radial tuberosity surrounded by the supinator muscle. And here you can see that there is increased signal into the distal part of the biceps tendon as well as in the supinator muscle, and this means that there is partial tear in the tendon as well as in the muscle itself. Then sometimes you get tendinopathy or tendon degeneration in the biceps tendon, diagnosed by the elevated signal of the tendon which remains intact. And this is the tendon which is going to the radius, and this is the supinator muscle, and here you can see some increased signal, but the tendon looks intact, and this is tendinosis, tendinopathy, or tendon degeneration. And this is a good example of biceps tendinosis. And the T1 weighted image, the tendon is swollen with intermediate signal. Also in the T2 weighted images, there is some elevated signal in the tendon itself. But here you can see that the tendon is more or less intact with no evidence of retraction, and this is tendinosis. The rupture of the brachialis muscle or the brachialis tendon is of course less common than the rupture of the biceps, and the biceps is frequently seen in the clinical practice, while brachialis tendon rupture is less common, as I have mentioned. Then here is an example, and you see this is the brachialis muscle, which showed diffuse increased signal due to muscle edema and hemorrhage. And the sagittal fat suppressed images, you can see that the biceps tendon is intact, while the brachialis muscle is diffusely swollen and involved by heterogeneous signal increase due to muscle edema and hemorrhage. Then we came to an important issue here, which is the anatomy of the radial nerve. And the radial nerve is formed by the posterior cords of the brachial plexus C6, C7, C8, and T1. This nerve passes between the medial and lateral heads of the triceps muscle. And about 10 centimeters above the elbow, the nerve passes between the brachialis and the brachioradialis, as you have mentioned, and I will show it to you once more in the axial images. At the level of the elbow joint, the nerve bifurcates into the superficial and the deep part. The superficial branch is sensory and is innervating the thumb, the index, and the middle fingers, while the deep branch, which is more important, is known as the posterior interosseous nerve, and it is a motor branch supplying motor power to the wrist and the finger extensors. Then the deep branch passes between the superficial and deep head of the supinator muscles, and as you can see here, this is the superficial branch, which is sensory branch, and this is the deep branch, which is a motor branch, passes between the superficial and deep heads of the supinator muscle. then this branch is prone to be compressed and entrapped by lesions around the elbow joint, resulting in what's known as posterior interosseous nerve palsy or radial tunnel syndrome or supinator syndrome. All these are the same names for the same pathology. Then compression of the posterior interosseous nerve, which is the motor branch passes between the heads of the supinator muscle, will lead to pain and the tenderness in the proximal forearm during activity. And there are some loss of finger extension in the patient compared to the normal cases. But being a motor branch, there should not be numbness or a change in the sensation related to the distribution of the nerve. Then the supinator muscle may show some abnormal signal, as you can see here. This is the radius and this is the ulna, and here this is the supinator muscle, which is relatively swollen and showing diffuse increase of its parenchymal signal. Then one of the common lesions that can cause compression of the posterior interosseous nerve is the presence of ganglion cyst near its course, and this is an example. Here you see a ganglion cyst showing high signal fluid in the T2 weighted images, and this is the ganglion cyst, and you can appreciate that the supinator muscle is slightly swollen and it shows diffuse parenchymal increase signal. Then there is a bursa which is related to the biceps tendon, which is known as the bicipito-radial bursa, and this bursa is located near the attachment of the tendon to the radius. And if the bursa is inflamed, it will accumulate fluid, and this fluid will compress the nerve, resulting in the same condition. Then the distension of the bursa, then this is the tendon and this is the bursa with fluid, which is of low signal in the T1, high signal in the T2. Sometimes after contrast it may show marginal enhancement, which indicates the presence of associated infection. And of course this bursa is liable for any pathology that can affect the synovium anywhere in the body, especially the rheumatoid arthritis, which may result in calcification and the presence of rice bodies, as similar to many of the bursae in the human body. Then this is a bicipito-radial bursitis. You see, this is the radius, and this is the supinator muscle, and this is the bursa, which is related to the biceps tendon. The bursa is markedly distended by fluid, and after contrast it shows some marginal enhancement, indicating the presence of inflammation. And this patient had a previous history of internal fixation of radial head fracture, and it presents by elbow pain, and the MRI showed the presence of distension of the bicipito-radial bursa by fluid of low signal in the T1, high signal in the T2, and after contrast injection it shows a marginal enhancement, denoting the presence of inflammation. And this is also the supinator syndrome, and here you see the distal part of the biceps tendon showing some increased signal within the tendon in both T1 and the T2 weighted images, as indicated by this long arrow. And here you see minimal fluid in the bicipito-radial bursa as well. Then the bicipito-radial bursa is distended by fluid together with projections of high signal in the T1 and low signal in the T2, indicating the presence of fat, and this is lipoma are present in the bicipito-radial bursa. Then this is also an example of bicipital radial bursitis in the T1 weighted image, and in the T1 weighted image with fat suppression after contrast injection showing marginal enhancement. The differential diagnosis of bicipital radial bursitis include the biceps tendon abnormalities like tear and the tendinosis. If there is some dislocation of the elbow, osteochondritis dissecans of the capitulum, radial head fracture, and other antecubital masses in this particular area like lipoma, hematoma, and the neuroma. Then we came to the medial compartment, and in the medial compartment we have to discuss the medial collateral ligament, the medial epicondylitis, the little league elbow, and the ulnar nerve entrapment. You should remember that the medial epicondyle is more prominent than the lateral epicondyle. Then in the axial images, you can easily appreciate that this is the medial epicondyle and this is the lateral epicondyle, which is less prominent. Posterior to the lateral epicondyle, you see the anconeus muscle, while posterior to the medial epicondyle, you see the ulnar nerve. And anteriorly, of course, you see the brachialis, and this is the pronator teres, as I have mentioned. Then the medial collateral ligament or the ulnar collateral ligament is made of three parts. The anterior component, which is very important, arising from the medial epicondyle and inserts into the coronoid process, this one. And the posterior part, which also arises from the medial epicondyle and inserts into the posterior part of the coronoid process of the ulna. Then the transverse part, which is not seen by MRI. This anterior part is the most important part of the ligament, which is usually seen in the coronal MRI, and this is the site of the medial collateral ligament of the elbow, particularly the anterior bundle. Then if you identify first that this is the radius, then this will be the ulna, and between the medial epicondyle and the coronoid process of the ulna, and you can see this low signal band, which represents the ulnar collateral ligament. And you remember, this is the anatomy of the nerves. The radial nerve is located here, and this is the median nerve, and this is the ulnar nerve, which is our target here in the elbow. Then this is the ulnar collateral ligament. The anterior bundle of the ulnar collateral ligament is well shown in the coronal images, either with arthrography or without. Then in the axial images, you may be able to see both bundles, the anterior bundle as well as the posterior bundle of the ligaments. But actually, we diagnose injuries of the ulnar collateral ligament from the coronal images. And we have to differentiate between two major issues. The first one is anything apart from complete tear of the tendon, like the sprain or the partial tear. All these are treated conservatively, but the complete tear of the tendon is important because it is treated surgically. Then in cases of complete tear, you should identify the site of the tear. Either it is towards the ulnar side, the humeral side, or in the mid portion of the tendon. Then because of the intimate relation of the common flexor tendon to the medial collateral ligament, sometimes whenever there is injury of the ulnar collateral ligament, there may be associated injury of the common flexor tendon. And differentiation between partial and complete tear is essential because the complete tear is treated usually surgically. Then this is an example of MR arthrogram of the elbow of complete tear of the ulnar collateral ligament near its ulnar attachment. In cases of arthrography, you can see that the contrast is leaking from the site of the rupture. And this is an example of rupture of the ulnar collateral ligament from its humeral attachment with contrast leakage at the site of rupture. And this is an associated injury of the ulnar collateral ligament as well as the common flexor tendon, which is severely swollen, and there is a heterogeneous increased signal due to hemorrhage and edema. And this is also an example of rupture of the ulnar collateral ligament near its humeral attachment, and this asterisk shows the diffuse soft tissue edema and contusion of the flexor muscles. And you see this is the site of the common flexor tendon here, but the muscle showed diffuse soft tissue edema and hemorrhage. Then this is an example of rupture of the ulnar collateral ligament, as well as contrast leakage. This is MR arthrogram, contrast leakage from the site of the tear, together with involvement of the flexor tendon as well. And this patient has diagnosed with tear of the ulnar collateral ligament that was surgically repaired. Then the graft is torn once more, and here you can see a defect within the graft itself, and there is some leakage of contrast from the site of tear. Then this is the humeral avulsion or tear of the ulnar collateral ligament with some leakage of contrast in a case of MR arthrogram. This is the ulnar collateral ligament, and this is the site of the tear. Then partial tear is sometimes diagnosed in the literature by what is known as the T sign. And the T sign refers to that there is some of the fibers of the ligament that have been torn, leading to some extension of the contrast media within the site of the rupture. And in order to understand this T sign, look at this drawing, and if you go back to the original image, then you can imagine the T sign. Many of the investigators usually say that this is a normal finding, and you can see it without any history of trauma or pain. Then, or sometimes they consider it as laxity of the ligament itself, but in other literature they consider it as a sign of partial tear. Then we came to the medial epicondylitis, which means that there is involvement of the common flexor tendon inserting into the medial epicondyle. And the manifestations include a weak grip and pain and tenderness when touching the inner side of the elbow, when shaking hands, when flexing the wrist towards the forearm. Then this is by name is considered as an overuse tendinopathy, which may proceed after that to partial or complete tear. Then the appearances in the MRI, either one of three. You may say that there is a swelling of the tendon with some increase in the T1 and T2 signals of the tendon, denoting tendinopathy, and or they may be partial or maybe complete tears. Then this is an example of torn flexor tendon origin. This is the medial collateral ligament, the ulnar collateral ligament, and the common flexor tendon is ruptured, and you see that the defect is filled by fluid signal of low signal in the T1 and high signal in the T2 weighted images. Then here you can see that the ulnar collateral ligament is intact. This is the ulnar collateral ligament, but the site of the common flexor tendon is markedly swollen, and it shows diffuse signal increase in the T1 and T2 weighted images. But if you look carefully, then you may see that the common flexor tendon is more or less intact. Then if you see this appearance, which is an avulsed bony fragment from the medial epicondyle, then you know that the common flexor tendon, which is attached to this fragment, is avulsed as well. And here is a avulsion fragment of the medial epicondyle, and you can see the fragment also in the MRI together with the plain X-ray, and the tendon is swollen with some increased signal, but the tendon is remaining intact. Then we came to an important issue, which is the medial epicondyle. This medial epicondyle, the center of ossification, appears about the age of 5, years. Then it unites with the humeral diaphysis by the age of 18 to 20 years of age. This epicondyle is an apophysis, meaning that it does not contribute to longitudinal growth of the bone. And this apophysis may appear normally fragmented, simulating a fracture, and this may be seen elsewhere in the body, like in the calcaneus, for example. Then the ulnar nerve runs in the groove posterior to the medial epicondyle, and this ulnar nerve is superficial to the ulnar collateral ligament, as I will show it to you. This is the sequence of ossification of the centers around the elbow, and you can remember them by this abbreviation. And the capitulum is the first one to appear, followed by the radial head, then the medial epicondyle, then the trochlea, and then the olecranian, and finally the lateral epicondyle. And most of the centers are ossified by approximately the age of 12 years. Then fractures of the medial epicondyle are usually inferiorly and laterally displaced by the effect of the flexor tendon, and this is an extra-articular fracture, and is considered the third most common pediatric elbow fracture after the supracondylar and the lateral condylar fracture, commonly seen at this age group. And there is valgus strain with traction on the medial epicondyle by the flexor tendon, and you can see in this drawing the site of the displacement of the medial epicondyle. And this is an X-ray, which is usually difficult in assessment of this fracture because of the presence of many non-united ossification centers, but this drawing may help you to see that this is the medial epicondyle, which is usually displaced inferiorly and laterally, as I have mentioned. Then this is a medial epicondyle fracture, which is easily diagnosed by the plain X-ray and also by MRI. This is T2 and this is T1, and you can see the separated fractured medial epicondyle. And also here in this frontal X-ray and lateral X-ray of the elbow, you can see a avulsion of the medial epicondyle and the adjacent part of the metaphysis, with obliteration of the anterior elbow fat bed and appearance of the posterior elbow fat bed, denoting the presence of hemarthrosis. Then little league elbow is a lesion which appears or affects the adolescent rowing athletes, and it will appear like that the medial epicondyle is fractured or slightly separated from the nearby humeral shaft, meaning that the physis here is relatively widened, and this injury is commonly seen in children and adolescents, as I have mentioned. Then this is the normal appearance of the medial epicondyle, and this is the little league elbow, where the medial epicondyle is slightly separated from the related part of the distal part of the humerus. Then here you see that there is a line of separation between the medial epicondyle and the humerus, with an area of linear increased signal in the T2 weighted images, and this is known as little league elbow. And also here you can see there is minimal separation of the medial epicondyle compared to the normal opposite side, and by MRI you see the separating line with diffuse increased signal of the affected epicondyle. And also here you can see that the medial epicondyle, there is a faint line in between the medial epicondyle and the humerus, and this line can also be appreciated here with some increased signal of the affected medial epicondyle. By the way, you can see this muscle which is known as anconeus epitrocularis. You know that the anconeus muscle is located laterally, but this a muscle which is considered as a normal variant seen related to the posterior aspect of the medial epicondyle. Then the ulnar nerve is crossing posterior to the medial epicondyle and superficial to the ulnar collateral ligament. Then if you look here in the axial images, you identify the medial epicondyle, but by its more prominence compared to the lateral one. And this is the medial epicondyle. Then if you look posteriorly, you can see the ulnar nerve. And this is the site of the ulnar nerve, which is located superficial to the ulnar collateral ligament. And this is the ulnar nerve, and this is the medial nerve, and this is the radial nerve, as I have mentioned before. And here you can see the brachialis tendon, and this is the biceps tendon. Then this is what we call the cubital tunnel, which is bordered deeply by the ulnar collateral ligament and superficially by the cubital retinaculum. And this cubital tunnel contains the ulnar nerve, and this is the appearance of the normal ulnar nerve, and this is the cubital retinaculum, and here you can identify the medial collateral ligament. The cubital tunnel syndrome means that the ulnar nerve is not looking normal, and it is presenting an abnormal signal and maybe swollen as well. And you remember the appearances of the median nerve at the level of the wrist joint. The nerve may be swollen or flattened with increased signal, and these findings can be also appreciated here. And sometimes you can see a cause, and many times you cannot see a cause for this cubital tunnel syndrome. The possible causes include the overuse or the subluxation and dislocation of the nerve from its normal course, humeral fractures with loose bodies or callus formation, nerve compression by bony spurs due to osteoarthritis, the presence of this muscle, which is anconeus epitrocularis muscle, the presence of soft tissue tumors, the presence of ganglia and hematomas, also synovial hypertrophy and inflammation by rheumatoid or septic arthritis, thickening of the cubital retinaculum, or the presence of a bony exostosis like osteochondroma from the related bones. And this is the medial epicondyle, and the posterior to it, and you can see the ulnar nerve, which is pointed to it by the arrowhead, and this arrow points to the muscle which is known as the anconeus epitrocularis. This anconeus epitrocularis is a muscle which is not normally present, but in some patients this muscle may be seen. This is the usual anconeus muscle, but this is the anconeus epitrocularis. This arrow points to the ulnar nerve, which is swollen and is of abnormal signal denoting neuropathy. And in this patient with osteoarthritis, there are some osteophytes impinging on the ulnar nerve and may lead to ulnar neuropathy. And here you can see that the ulnar nerve is swollen and is of increased signal at this level, but lower down it may show normal caliber and normal signal. Here you cannot identify a specific cause for this ulnar neuropathy. And this particular example, you can see the anconeus epitrocularis muscle, and you can see the ulnar nerve, and in the T2 weighted images, and you can see that the ulnar nerve is of increased signal denoting neuropathy or compressive neuropathy. Anconeus epitrocularis is an abnormal muscle that is located superficial to the ulnar nerve, and the ulnar nerve in this particular example, this is the ulnar nerve, and in the T2 weighted images it shows diffuse increased signal denoting compressive neuropathy. Then finally we came to the lateral compartment of the elbow, where you can see the lateral collateral ligament, the lateral epicondylitis, which is known as the tennis elbow, and the capitulum osteochondral defects. You remember that the medial epicondyle is more prominent than the lateral epicondyle. The lateral collateral ligaments is formed of three bundles, and the most important of them is the lateral collateral ligament, or the radial collateral ligament, which passes from the lateral epicondyle to the radial head. And this part is known as the lateral ulnar collateral ligament, because it goes from the lateral epicondyle to the ulna, and finally the annular ligament, which is not usually seen by MRI. Then here you can see the radial collateral ligament and the annular ligament, and I will show these structures to you by MRI. Then first identify the site of the radial head. Then you will see a low signal band passing from the lateral epicondyle to the radial head, and this is the lateral collateral ligament. Superficial to it, you see a more thicker low signal band, which represents the common extensor tendon. Then this is the medial or the ulnar collateral ligament, and this is the lateral collateral ligament, and this band is the lateral ulnar collateral ligament, which is sometimes seen, but the radial collateral ligament is the one which is very important. And here you can follow the course of the lateral collateral ligament or the radial collateral ligament. This is the ligament, and the superficial to it is the common extensor tendon. Then you follow the ligament and the tendon. Then you follow the ligament and the tendon. Then you go to finally to the ligament and the tendon. This is the common extensor tendon, and this is the lateral ulnar collateral ligament going to the ulna, where you can see it here. And this is once more the anatomy of the lateral collateral ligament. This is the radial collateral ligament proper, and this is the lateral ulnar collateral ligament, and you cannot see the annular ligament. The lateral epicondylitis means that the common extensor tendon is of abnormal signal, meaning that there is tendinopathy, or partially torn or completely torn. And you should remember that about 95% of patients with tennis elbow do not play tennis actually. Then this is an overuse syndrome of the common extensor tendon. There may be some degenerative changes presenting in MRI by increased signal of the tendon in the T1 and T2 weighted images. This is 7 to 10 times more common than medial epicondylitis, and it affects the patients in the 4th and 5th decades of life. Then this first identify the radial head. Then this is the common extensor tendon, which shows diffuse increased signal denoting lateral epicondylitis. Then where is the radial head? This is the radial head, and this is the common extensor tendon, which shows diffuse increased signal diagnostic of lateral epicondylitis. This is the radial head, and this is the common flexor tendon, which has an intermediate signal in the T1 and a little bit increased signal in the T2 weighted image, denoting lateral epicondylitis or tennis elbow. And this is the radial head. This is the common extensor tendons, and you see the increased signal diagnostic of lateral epicondylitis. Tendinosis is in the form of signal increase without tendon tear, which may progress to partial tear and even full thickness tear. And there are some grading or staging of the lateral epicondylitis known as the Nurschel staging. Stage 1 means that there is reversible inflammatory changes. Stage 2, irreversible inflammatory changes of the common extensor tendon. Rupture of the common extensor tendon is stage 3, and secondary stages changes like fibrosis and calcification are indicative of an advanced stage 4. Then here you see that this is the radial head, and this is the common extensor tendon, where you can see some calcification, which are not of course appreciated in the MRI, but here you can see the increased signal denoting the presence of degenerative changes. But you should remember that calcific tendonitis is infrequent and is usually associated with chronic inflammatory changes as similar as those seen in the supraspinatus tendon. Then look to the radial head, or in the axial images you can identify the medial epicondyle by its prominent appearance. The lateral epicondyle is here, and this is the attachment of the common extensor tendon, which shows some increased signal, and in the coronal images and you can see the real increase in its signal. The differential diagnosis of lateral epicondylitis include the presence of occult fracture, osteochondritis dissecans of the capitulum, which is one of the lesions that are commonly seen at that site, lateral osteoarthrosis, and lateral ulnar collateral ligament instability, as well as, you remember, the radial tunnel syndrome. Then the osteochondral defect, which is previously known as osteochondritis dissecans, is in most of the cases is of unknown etiology, but there are suspected causes which include repetitive trauma, restriction or loss of the blood supply, hereditary factors, endocrine factors, anomalies in the bone growth, steroid therapy, and repeated, often unrecognized trauma may result in this, and sometimes the metabolic abnormalities. And this osteochondral defect is a rare condition, and is the overall incidence is about 15 to 30 per 100,000 people, and the age incidence about between 10 and 20 years of age. It is a little bit more common in females compared to males, and it affects most commonly the anterolateral aspect of the capitulum, and this is the most common site for osteochondral defects in the elbow. The capitulum, which is related, of course, to the radial head, or articulates to the radial head, and many times the X-ray may show normal findings, but sometimes you can see this lucency or even a separated bone fragment related to the capitulum. But and the CT scan and the MRI, you can see the osteochondral ulcer and the defect, and you may see also displacement of the bone fragment at this site. Bone scan will show non-specific increased uptake at the site of the lesion. Then by MRI, and you can see this is the radial head and this is the capitulum, where you can see this osteochondral defect, which is of low signal in the T1 and T2, denoting the presence of fibrosis. Sometimes you may use MR arthrography for a staging of this osteochondral defect and the detection of loose fragments. And these are the stages of osteochondral defects in the capitulum. Stage 1 is the presence of bone marrow edema, and this is a stable stage. And then loss of the articular cartilage with low signal rim surrounding the fragment, and this is also a stable stage. Then buckets of fluid around the undetached fragment, also the displaced osteochondral fragment. Both these stages are unstable. Then this defect is of a very good prognosis, and it usually reaches complete revascularization of the capitulum in about 14 months. As a self-limiting condition, and the healing is good. And this is the coronal reformatted image of MRI of CT of the elbow, and you see the typical appearance of osteochondral defect in the region of the capitulum. Then as similar to any other joint in the body, synovial osteochondromatosis, meaning that there are numerous loose bodies in the joint which are the result of synovial metaplasia into cartilage, which later on calcify. This disease can be easily diagnosed by the plain X-ray, by CT, and by MRI. And the imaging findings are in the form of widening of the joint space, sometimes bone erosion, and of course too many calcified loose bodies, and finally the joint will develop osteoarthritic changes. This is the endoscopic appearance of osteochondral loose bodies, and this is the MRI appearance of in synovial osteochondromatosis. There is a big joint effusion and too many low signal loose fragments. Finally, elbow osteoarthritis is is not commonly seen as those in the knee or the hip, but the similar manifestations are usually identified. Then you see narrowing of the joint space, subarticular bone sclerosis, osteophytic clipping of the articular surfaces, subarticular pseudocystic changes, and maybe the development of intra-articular air due to degeneration of the cartilage. And you remember that the osteophytes of osteoarthritis may impinge on the ulnar nerve in the cubital tunnel, resulting in ulnar neuropathy. And this is osteoarthritis of the elbow, showing the classic manifestations: narrowing of the joint space, osteophytic clipping, and there is some loose bodies within the joint. And this arrow points to the ulnar nerve, which is somewhat away from the osteophytes here, projecting from the olecranon and the humerus, but many times these osteophytes may impinge on the ulnar nerve, resulting in ulnar neuropathy. And finally, there are some of the take-home messages, which include: the elbow is a complex hinge joint with 3 articulations. Then the biceps tendon injuries tend to occur in middle-aged men. Lateral epicondylitis is much more common than medial epicondylitis. Medial collateral ligament injuries are often occur in overhead throwing athletes. The synovitis is a non-specific finding indicating infection or inflammation. Pseudo defects in the capitulum should not be mistaken for osteochondral defects, and the elbow is a common site for entrapment neuropathies, particularly the ulnar nerve. هذا وبالله التوفيق والحمد لله رب العالمين والسلام عليكم ورحمة الله وبركاته.